Sorry about these. The technology gods are conspiring against me at the moment.
In the meantime, Jamie, I might introduce you to the audience.
Go for it. Sorry, everybody.
Good. So this is Jamie. He's a final year haematology advanced trainee and completed his basic physician trainee at Royal Perth and Fiona Stanley Hospital in WA before moving to Melbourne for his haematology training. He spent 3 years at Peter Mac and Royal Melbourne Hospital in both clinical and laboratory roles, and now he's at the Austin. So Jamie, if we can get these slides working, what we can try doing is you can send me the slides and I'll share them, and then I'll move through the slides.
Oh, I think we may have maybe ready. Give me. Dropbox tells me it has 1 second left. Here we go. Alrighty, can you see this?
Yes, we can. Fantastic.
Yes. All right. So I'll get start. So thanks for the introduction, Gabriel. My name is Jamie Kuzich. As Gabriel's pointed out, I'm currently final year haematology registrar up at the Austin. The title of my presentation, "Hi, it's Jamie, the Heme Reg," is something I say about 40 times a day. So I thought it was apt to start my presentation with this. I had a reasonable difficulty working out what to talk about. I thought back to what I knew about haematology or what I'd want to know when I was a medical student. And it was difficult because I knew absolutely nothing about haematology at university. And by the nature of your group and this night, I have to assume you know something about haematology to at least be interested in it. So there's a certain gap between me as a medical student now as a haematology registrar and yourselves as predominantly medical students interested in haematology. So this was the brief that Gabriel gave me. He asked me under the sort of the banner of careers of haematology to talk a bit about what my job involves, a bit about the specialty and the pathway into haematology. I'm going to invert that slightly and start a bit by talking about my pathway, which is also known as how I sort of accidentally fell into haematology. I'll briefly talk about what I spend my time doing now and what I've been doing over the last 3 and a bit years as a heme reg. And then a little bit of time on why I like haematology so much. So the first thing to say is that haematology is a really diverse specialty, and anything that I talk about tonight is really just, with the excuse of using a cliche, the tip of the iceberg. It really represents my experience in dipping my toe into a number of the different aspects of haematology. But one thing I've come to know is that whilst from the outside, haematology looks like a very niche, small specialty, within it, it's incredibly diverse, and that expands both the types of diseases we manage, which we often tend to lump into malignant and non-malignant. However, within each of those categories, there's a huge amount of diversity, as you can see outlined on the right. There's a huge difference in the way haematology is practiced in the lab and clinically, and in that really lovely space in between. in the setting in which haematology is practiced, in the inpatient setting, the outpatient setting, in the community, in academic hospitals, in peripheral hospitals, in public and private, and a huge array of different acuities and types of patients that you look after. So what I'm going to talk about now is really just my tunnel vision experience of what I've experienced over the last 8 or so years of being a doctor. So this is a timeline of drug approvals for myeloma over the last 60 years. It's a timeline that you can replicate for many other diseases, be it acute myeloid leukemia, diffuse large B-cell lymphoma. Myeloma is a bit of a poster child in the number of drugs that have been approved in a short period of time and the consequent change in its therapy. And I stumbling across this timeline, I thought it quite nicely aligned with the timeline of my medical career. And I think highlights why, one of the reasons why I've become so excited about haematology. So my equivalent of my drug approval timeline looks something like this. I started my medical degree at UWA in 2005. I did my first 3 preclinical years. I took a year off in 2008 and spent most of the year traveling and learning how to speak Spanish. I then spent a year in 2010 in my second last year in the Rural Clinical School in Broome. And then somebody decided to give me my degree and I started my intern year in 2012. Up until this point, no haematology. I think I briefly remember trying to work out in third year pathology the difference between Hodgkin and non-Hodgkin lymphoma, and once stumbling across studying for my 5th year exam the idea of thrombotic microangiopathies. But really I was clueless about haematology. I then got my first taste of haematology when I started basic physician training in my 3rd postgraduate year, and then I was lucky enough to do another heme term by chance about just over 12 months later. I sat my FRACP exams in 2016 at Fiona Stanley Hospital, and then the following year I moved to Melbourne and started my haematology training at Peter MacCallum Royal Melbourne. It stayed on for another 2 years. I did my laboratory training where I sat my FRCPA exams, and then this year I've moved to the Austin for my final year of clinical training. So what I'm going to speak about is really this first segment, how I got interested in haematology and how I fell into it. The second segment, a little bit of sort of the mechanics of how haematology training works, and then a bit of a summary about what I do now. So like I've mentioned, for the first 7 or 8 years of my medical career, I knew absolutely nothing about haematology. My interest was first peaked when I was a PGY2 resident doing a general year, doing a lot of evening and night cover. And the first thing I noticed that haematology patients always seem to be the sickest, the most complex. But every time you'd go to the heme ward for this terribly unwell patient with multiple issues that I barely understood, I noticed that the haematology ward seemed to be the most in control. The nurses knew everything that was going on. They guided you through it. It was just calm and together. I was totally baffled by most of it though. It was full of acronyms. I would call up the heme reg and say, this is Mary Smith, who's D2C5, flag IDA, CR2, AML, and I had no idea what any of them meant. I was talking to a friend of mine who has just come back to clinical medicine after a long break and is working as a resident at another tertiary hospital, and he happens to be covering haematology. And he sent me a text message asking me what this C2, D11, D12 gene was that all of the febrile neutropenia patients used to have. And he was a little bit embarrassed to find out that C2D12 stands for cycle 2, day 12, rather than a particular common mutation in diffuse large B-cell lymphoma patients. But haematology was a big mystery to me. And I, as a result of this, when I finally decided to do basic physician training rather than critical care training, I specifically asked to do a haematology term in my first year, and I was lucky enough to do it as my first term. And the first thing that struck me about haematology before I got into the fascinating biology of it was more the team and the human aspects of haematology. The therapeutic relationships that I established with patients as a haematology resident were far different to any therapeutic relationships that I had had in previous terms. Haematology patients go through an unbelievable amount of hardship in their diagnosis and their treatment, but somehow come through it with a huge amount of optimism and strength. And I found that these patients who I'd be seeing day after day, who'd be experiencing really, at times, really difficult complications of the disease and their treatment, I was really struck at how much of a team the two of us, that we felt like, both myself and the patient and the rest of the unit. I also noted something about haematologists that was somewhat unique. These were consultants who had areas of expertise in particular niches, but they all seemed to be really across their patient's whole course. They took ownership of their patients, they followed them from diagnosis through relapse, through second-line treatment, through death, and sort of carried them through that whole period of time. And it was an inspiring way of approaching patient care that I had not come across in many other places. The patients were obviously complex, and for a resident who was previously interested in critical care, it was extremely exciting to manage a patient who had lots of acute issues at the time. But what I'll touch on again is that the haematology unit I worked in at Royal Perth was one of the first real units that I worked in. It was clear that from the consultants to the registrars, to the residents, to the nurse coordinators, to the lab scientists, to the transplant coordinators, to the apheresis staff, to the scientists, everybody was really across the unit and came together twice a week at the unit I used to work with. Everybody knew everybody's patients, and it was a really, really nurturing and supportive environment to work in. The patients and the biology themselves started standing out to me as well. There were 3 patients that really sprung to mind from when I thought back to this time. One was a 29-year-old man who was initially diagnosed with CML, but had a really unexpectedly poor response to his tyrosine kinase inhibitor therapy, and then presented about 3 months later with spinal cord compression, which was due to an epidural chloroma, which is essentially a big lump of acute myeloid leukemia outside the bone marrow. He had induction chemotherapy and was in hospital for over 2 months, and was one of the sickest patients that I'd looked after, but also one of the patients that I came to know the best throughout that time. By contrast, another woman that I looked after was diagnosed with AML at a similar time. She cruised through her treatment, got into remission and stayed in remission, and I never saw her since. And when I looked her up before I moved to Victoria, she was still in remission. Another woman who was in her 50s who had an allogeneic stem cell transplant for acute myeloid leukemia 10 years previously, and was really thought to be cured, for lack of a better term, presented with relapse disease and unfortunately died in the midst of her subsequent treatment. And what struck me was that these were 3 patients who in theory had similar diseases that had the same name, but who had entirely different treatment courses and who were very difficult to pick out. They all received essentially the same treatment, but all responded very differently. And that idea of biological heterogeneity stuck with me as I went through. I sort of started thinking about this idea of Schrodinger's cancer. I think some of you will be familiar with the idea of Schrodinger's cat. It was an experiment I don't fully understand the quantum physics of, but in essence, there was a cat placed in a box and there was a contraption rigged up. And something happened with the contraption, and before the box was open, the cat was both alive and dead at the same time. And this is meant to demonstrate some ideas about quantum physics that I don't fully understand, but it sort of reminded me about how some of these patients that I was looking after seemed to be. We had a patient with diffuse large B-cell lymphoma. This is a PET scan that you can see, who was treated with R-CHOP chemotherapy, a standard frontline treatment for lymphoma. And one of the patients at the bottom had a complete response and was in remission and is probably still alive now, whereas the other patient had completely refractory disease and went on to die shortly afterwards. But they all had the same treatment, they all had the same disease, but they all responded completely differently. And this is something, the little seed that was sown with me when I started thinking about the kinds of specialties that I might be interested in pursuing. Somewhat fortuitously, at the end of the next year, my general medicine registrar job that was supposed to be down in the southwest of WA got cancelled because of some administrative issues. And I got offered the chance to do another job in haematology, and knowing that I was thinking about it, I took this opportunity. At this point in time, I knew a little bit more. I'd been studying for the FRACP exams. And I started to really see how the clinicians I was working with were really interrogating the biology of the disease to influence their treatment decision-making. I remember discovering the idea of FLT3 ITD mutations, which are a common and poor risk mutation in acute myeloid leukemia, and how they influence decisions that were being made regarding allogeneic stem cell transplant. I saw us start to use some new drugs that had a bit of an immunological flavour. A couple of acute lymphoblastic leukemia patients were treated with blinatumomab and inotuzumab, some new drugs that have been recently approved following some successful clinical trials. I also started to see patients who were bearing the successes of prior biological discoveries. I looked after a patient with acute promyelocytic leukemia, which was previously really considered just as some type of acute myeloid leukemia, but after the discovery of its real canonical genetic mutation and treatment targeted towards it, it's now a leukemia that has an overall more than a 90% long-term survival rate. And the patient I looked after was a patient who was a Jehovah's Witness who 10 years prior would have had no chance at all of surviving the intense induction therapy. But he was treated with essentially a chemotherapy-free regimen consisting of essentially high-dose vitamin A, or transretinoic acid and arsenic, and survived his treatment and stayed in remission. At this point in time, I started to get involved in some research projects and started to talk to people about wanting to do haematology, with all these factors combining to help it stand out from the other candidates like nephrology and immunology and medical oncology. The following year, I sat my RACP exams and I started applying for jobs, and then decided to move to Melbourne. This was as much a personal decision as it was a professional decision. Growing up in Perth, it's a pretty isolated city. I'd always wanted to spend some time outside. And Melbourne seemed like the perfect opportunity. And I ultimately decided and was successful in getting a job to start clinical haematology training at Peter Mac and the Royal Melbourne. And I spent about a third each of the year looking after lymphoma patients in the inpatient setting, patients undergoing allogeneic stem cell transplants, and patients who are receiving chemotherapy in the day oncology unit. So some of you, I'm not sure exactly where you guys all are in your training, but whether you spend time in hospitals or whether you're at the start of your medical degree. But I thought it was worthwhile explaining what a clinical haematology registrar actually does. So registrars generally tend to be the senior of the junior medical staff. They've usually been training for at least 4 to 5 years and often have chosen their specialty. And they often seem to act as this sort of first line of defense in units. And as a clinical haematology registrar, my time is really split between managing patients in the inpatient setting, the outpatient setting, and also providing a kind of consultative type service for the hospital. Looking after inpatients, we really look after the spectrum of haematological disease. Inevitably, by the nature of the acuity, a lot of the patients we look after have acute leukemia, are undergoing autologous or allogeneic stem cell transplant, or are in hospital due to complications of their treatment. And this is just me looking through our current inpatient list for an idea of the kinds of patients we look after. We've got a patient who's got an invasive fungal infection after having a transplant 4 years ago. We've got 2 patients undergoing an allogeneic stem cell transplant at the moment, 4 patients undergoing induction treatment for acute leukemia, a couple of patients coming in for consolidation treatment, and a smattering of other hematological malignancies and other hematological issues that are being investigated. In the outpatient setting, we look after patients who are receiving treatment in the day oncology unit, who are being seen in the outpatient clinic. And this typically comprises the less acute side of hematology, patients with various lymphomas, patients with myeloma, immune cytopenias of various description, myelodysplastic syndrome. And just looking back at my clinic list from the first part of this week, these are a few of the patients that are featured. A new young man with a new diagnosis of Hodgkin lymphoma, an elderly man with a new diagnosis of mantle cell lymphoma, a man we're following up post-discharge who presented with autoimmune hemolytic anemia, who I suspect has myelodysplastic syndrome as well, and again, a smattering of other undifferentiated problems to tease through. But what's somewhat unique about haematology is we also provide a consultative service for the rest of the hospital. Patients from other specialties get all sorts of hematological issues, blood clots, significant bleeding, unexplained cytopenias, people who are going to have operations or on blood thinning drugs. And in my current role, I'm taking a lot of calls from this group. And this is really a series of calls I've had in the last 2 days. I've got a woman in the ICU who's got a pregnancy-associated thrombotic microangiopathy, a patient with severe ITP who was picked up before his hip replacement that we've had to manage before his procedure, a patient after a hip replacement actually, who developed severe vancomycin-induced thrombocytopenia, lots of patients with blood clots, liver transplant patients with clots and DIC, and all sorts of other incidental findings. So this sort of gives you an idea of the span of work that as a clinical haematology registrar I do at the moment. This is a day in the life. This is sort of a composite of a couple of days over the last fortnight. We generally start my day about 8 o'clock on the ward. Saw a few patients who've been admitted from overnight, with one patient who was suffering a complication of his treatment, another woman with a new diagnosis of pancytopenia, yet to be diagnosed. After seeing those patients, we got together with the laboratory team and went through the bone marrow biopsies from the previous week, reviewing all the new diagnoses. then went back to the ward to see the remaining 15 or so patients, ran into the ear, nose and throat and the infectious diseases team who have been consulting on our post-allograft patient with the invasive fungal infection. This multidisciplinary type of conversation is very common in haematology patients who often got lots of complicated issues. I've got all of the ID registrars I've worked with throughout my life. I've now got on speed dial, and a lot of them I'm friends with as a result of how much we dealt with each other. I then caught up with our multidisciplinary team on the ward to make some complex discharge planning decisions about a patient who'd been in hospital for the last 2 months with a lot of issues after his transplant, was going to rehab. Nurse coordinators are an integral part of the units we work in, and tend to do a lot of the legwork and coordination with patients undergoing therapy. So I caught up with Vanessa, our nurse coordinator, to work out who was coming in, who was going home, who was having bone marrows, to assess their response. I then got in touch with a colleague at another institution across town about one of our patients who unfortunately had rapidly relapsing AML, to try to get them on a clinical trial using a novel agent. And then my day was interrupted by a phone call from Ballarat with a new patient with a high white cell count, acute kidney injury, who was actively bleeding from his gums and his conjunctiva. And so I started putting the wheels in motion to get this patient down to the Austin, and worded up the lab about the need for an urgent bone marrow biopsy and diagnostic assessment. Then popped over to the ortho ward to see this patient with vancomycin-induced thrombocytopenia, and tried to sort that out before making it to the myeloma MDT, where we discussed all the new myeloma patients diagnosed in the previous fortnight. Then prepared things for our transplant patients that were due to be admitted in the coming week, and then headed down to the lab to look at our newly admitted patient's bone marrow aspirate and flow cytometry to work out what she had. Went back up to the ward, met with this patient and counselled her about her new AML diagnosis, and talked about various treatment options. After I'd quickly had a look at the most recent data looking at venetoclax combinations for elderly AML, which we're trying to utilise more of up here at the moment. Just after I finished that, this patient from Ballarat turned up, clearly unwell with a likely new diagnosis of acute monoblastic leukemia with active bleeding issues and active tumour lysis. I spent some time with him, sorting him out, making a plan for the evening and handing him over to the evening reg, and then headed home to think about the research project that I had originally planned to spend today working on. So that's a snapshot of my time that I spent as a clinical haematology registrar, but what about in the lab? So I spent my middle 2 years of training in the lab at Peter MacCallum and Royal Melbourne. And the lab's a really different pace. You can see from the way that I played that day out that clinical haematology can be, as particularly as a registrar, can be extremely busy juggling lots of balls in the air. The lab gives you a bit of time to slow down and get to know the diseases that you're looking after. Haematology is a specialty that relies heavily on diagnostics to make accurate treatment decisions. And I always used to think of the lab as being this sort of black box that a question went into and an answer came out of. But spending time in the lab, you really get to understand both disease biology and how we use various diagnostic tools to tease apart disease and guide treatment decisions. But what you realize though is the limitations of these tools that you have, what you can use them for, what you can't use them for, what kind of questions can be answered and what questions can't be answered. And these 2 years in the lab were really formative for me, both as a clinician now, but also my understanding of haematology more generally. You can see on the right, this is just pulled from an interesting case we had last year of a patient who turned out to have a very unusual trilineage acute leukemia. That is a leukemia that expressed antigens that are present on myeloid cells, B lymphocytes and T lymphocytes, which represents only really a tiny proportion of acute leukemia. And here are 3 different modalities that we use to diagnose this. You can see that picture in the bottom left corner is the bone marrow aspirate, which showed an excess of blast cells. The flow cytometry that was performed next, which are those little dot plots on the right. This is an assay that helps us identify the types of proteins and other antigens that are expressed in and on the cell surface, through which we first started to think that this patient may have had this unusual leukemia. And up in the top right, you can see immunohistochemistry stains on slices of bone marrow trephine that again helped us firm up this patient's diagnosis. So now is probably a good idea to talk about haematology training. This is sort of the nuts and bolts of how you end up where I am now and what things you need to go through. Haematology training is slightly different to a lot of other specialties in that we've got these 2 faces. We've got our friend Janus there, looking forward and looking backward. Clinical haematology training and laboratory haematology training technically do exist separate, but they frequently exist together. And there are really three pathways within haematology training, that is. On the one hand, clinical haematology training is administered through the Royal Australian College of Physicians and has you come out as a clinical haematologist. Conversely, laboratory-only training through the Royal College of Pathologists is its own separate training program. But the vast majority of trainees at the moment in Australia tend to do dual training with both the College of Physicians and College of Pathologists. And this is sort of what it looks like. Here's a rough timeline, which obviously can differ person to person. But for both the dual training and the clinical haematology training, an essential component is the basic physician training and associated exams, which is a 3-year program which you can start anytime from your second postgraduate year. I started it in my third, but the earliest you can start is your second. And that involves doing 3 years doing various medical specialties as a resident and a medical registrar, which culminates in 2 exams in your 3rd year of training, both a written exam and a clinical exam. If you pass both of those exams, you can then apply to get into an advanced training program, which is where you choose your specialty like haematology or oncology or neurology. If you choose to do dual training, typically what people tend to do is to do a first clinical year as a clinical haematology registrar before entering laboratory training, which is a consecutive 2-year program. You can do 2 clinical years first and then 2 laboratory years, and that's becoming more common recently. The nuance of doing dual training or doing any laboratory training is you do have to sit more exams. Firstly, now recently introduced, to get into laboratory training, you do have to sit the Royal College of Pathologists Australia laboratory exam, which is called the Basic Pathological Sciences exam. I didn't have to do that, but you do now. And then in your final year of laboratory training, you sit 4 exams: a morphology exam, a written exam, a dry practical exam, which examines things like the flow cytometry plots we saw earlier, and then a viva. And then your final year of training, you have to sit 1 more lab-related exam as a viva. Following your lab years, you need to do a second clinical year, so totaling a total of 2 clinical and 2 lab years before becoming a fellow of both the College of Pathologists and the College of Physicians. The other version is a single stream. So for clinical haematology, after passing your basic physician training exams, you really just need to do 2 clinical haematology years and then a non-core year, of which 6 months need to be in the lab. But pertinently, there are no lab exams. Now, if you're interested in mostly the pathological side of things, there is a 5-year program administered by the RCPA that you can start in your 3rd postgraduate year, in which you sit the same set of laboratory exams sat by the dual trainees over those 5 years. So lab and clinical integration is something worth talking about. In my opinion, it's one of the best aspects of haematology and something that in my final year of training now I'm really starting to appreciate. I think pertinently, whilst it does add more time and more exams to your training, what laboratory training allows you to really do in combination with clinical training is to really both understand the fundamental details of both the disease biology you're looking after, as well as the tools that you're using to diagnose and monitor patients. But with your clinical training, you also get a much better idea of the context in which you're using these things, and you get to really see both the wood and the trees. Given that clinical decisions are really heavily reliant on diagnostic tools, I personally think that doing lab training has made me a better clinician, and I think make a lot of people a better clinician. And it's extremely satisfying now to be able to integrate these 2 aspects into looking after a single patient. Here's 2 examples from my on-call so far this year. This is a call I got at the end of the day from ED, who had a 42-year-old man who presented with dysarthria and dysphasia. A CT scan that had shown he had an acute pulmonary emboli, and he had pancytopenia. So I went down to the lab because the lab register had gone home already, and I had a look at the blood film. And what you can see here is 2 abnormal promyelocytes, which have a typical morphology of a particular type of acute leukemia called APML, which has a very specific treatment, which rather than wait until the next day we started then, I went to the ward, picked up the all-trans retinoic acid and walked it down to the emergency department and handed it to the man in a cup. The second call happened, I think, maybe in the same on-call period, where I was driving home and the rheumatology consultant gave me a call concerned about a 46-year-old woman he was looking after who had a mixed connective tissue disease, who presented with acute renal failure, extremely high blood pressure and low platelets. So I turned my car around, went into the lab, pulled up the film and had a look. And what it showed is an extremely abnormal appearance that was characterized by a high number of fragmented red blood cells or schistocytes. And this was quite typical of a syndrome called microangiopathic hemolytic anemia, which again is an urgent diagnosis and needs urgent treatment. And as a result of this, we then initiated both plasma exchange and also a dose of a drug called eculizumab, which is the world's most expensive drug at the moment. So these are just two very simple examples of very simple assays or very simple tests that were drastically able to change these two patients' treatment in the moment that I was able to initiate, both based on my clinical training and my laboratory training. So at the end of all of this, I've sort of come back to looking at this idea of Schrodinger's lymphoma. And whilst over the intervening 4 or 5 years, R-CHOP is still the same treatment that we give really all of our frontline lymphoma patients, what I've come to realize is that beneath all of this is a huge amount of biology, that some of which we're able to implement in clinical practice and some of which I hope we'll be able to start utilizing in new treatments to improve our patients' outcomes. So haematology is also an extremely academic specialty. The pace of discovery and the pace of development is huge, and there's a number of changes that have happened even just the 3 and a bit years that I've been a haematology registrar. And a result of this in your haematology training, there's a lot of opportunities to ask questions, to learn research methodology, and to start getting involved in untangling some of these biological questions that underpin the heterogeneity of outcome amongst our patients. So here's just a sort of a smattering of some of the projects that I've been involved with, some of them very clinically orientated, some of them much more laboratory orientated, as well as having the opportunity to be involved in designing prospective clinical trials, both in lymphoma and allogeneic stem cell transplant. And so if academia is something you're interested in, haematology provides a wealth of opportunities for it. So I'll wrap up shortly, but I was thinking about why I like haematology so much and why it's suited me so well. I think the first thing to say is that haematology is niche. It relies on individual expertise, but it also relies on a huge network of multidisciplinary players. And it's something I find particularly enjoyable, interacting with people from multiple specialties and multiple disciplines. You get to be an expert. No one else understands the acronyms, but you also have to be a real generalist to look after complicated, sick patients with multiple complications of their disease and their treatment. It's a specialty that really allows you to provide continuity of care and develop really strong therapeutic relationships with patients along disease courses that can span many years. But also it has this really strong focus on the biological underpinnings of disease and management, and is a specialty with a real commitment to translating biological discoveries into treatments to improve patient outcomes. And what I like about it as well is that we've got enough therapeutic successes. We cure some patients, but there's a huge amount of scope to apply discovery to improve patient outcomes. And that's why I find it a really exciting discipline to be in. So at the end of all of this, at the end of my drug discovery timeline, about to finish my training, I'm considering about what the next steps are. So what I can tell you is that there are lots and lots of ways that your career can look like after haematology training. I've had a bit of a drive-by experience of lots of aspects of haematology, but at the end of all of this, you can really choose as to what blend of the clinical, of pathology, of research you'd like to make, whether you'd like to be involved in the public health system or work mostly in private, whether you'd like to be a single disease expert or somebody who looks after lots of different diseases. And it's a specialty that really allows you to find your niche based on whatever inclination or interest or personality type you have. It's an incredibly exciting place to be. So I'll finish there. This is a megakaryocyte that I thought looked like a snowman that I found in a patient's bone marrow a few years ago. And on that note, I'll open the floor to questions.
Hi, Jamie. Thanks for your talk. I'm a third-year medical student. I just had a question about after training, working both in the lab and also clinically. I've kind of heard conflicting things about this. I've sort of heard from one of my placements that people tend to specialise either in the lab or clinically, and then I've also heard that a lot of people do both. Can you sort of, I guess, give some information on sort of like the distribution of those type of jobs?
Sure. Now, this is something that I've probably not got all of the insight into, but my general observation has been that the answer is it depends. And it depends on the centre, depends on the department, depends on the individual. There are some centres where laboratory and clinical haematology are very split, and people tend to focus on becoming experts in one of those areas. Having said that, for clinical haematologists, the majority of which, a number of them who've had laboratory training, still clearly utilise all of that information in their training and their decisions. Whereas other centres that have a much more generalist approach tend to have haematologists that work across both of those spheres. So again, it really depends on the centre, it depends on the focus of the department, and it depends on the individual. So both, in essence, both are true. Sorry, Gabriel, I don't know if you want to save maybe questions for the end.
Yeah, awesome. Yeah, thanks, Jamie. That'd be good if questions could be saved for the end. Could I also just ask people who are attending to put their full names, just so we know just so we know what the attendance is. Thank you. And I'll introduce our next speaker now. But first, Jamie, thanks for the amazing presentation. That was really good, and I've learned, I think, a lot about haematology that I didn't really appreciate before this presentation. I think it was a lot more, a bit more confusing to me, the dual specialty components. So I'll be introducing Mark Dawson now. Mark, are you there?
Yeah.
Awesome. So Mark is Professor Mark Dawson is a clinician scientist and the Associate Director of Research Translation at Peter Mac. His research interests is studying epigenetic regulation in normal development in cancer, and his research has actually helped find first-in-class epigenetic therapies, resulting in various clinical trials across the world. Mark is also a professor at the University of Melbourne and the Sir Edward Dunlop Fellow for the Cancer Council of Victoria and a HHMI International Scholar. Additionally, in recognition of his research achievements, he's been elected to the Australian Academy of Health and Medical Sciences. Thanks so much for coming today, Mark. Take it away.
Thanks, Gabriel. I guess Eric gave you that, did he? That spiel about myself. Let's see if this works. Okay. Whilst we're starting, do I take it that everyone here is a medical student? Is that right? Gabriel, I don't know if you have an answer for that.
Yep.
Yeah, everyone here is a medical student as well.
So I imagine almost everyone will be medical students. I think the advertising on Twitter may have let people who are medical students in, but all of our advertising on Facebook has been done to medical groups.
Okay. All right. Okay. So let's start. I'll just tell you a little bit about my road that I travel. So I started probably down this journey a little bit earlier than Jamie. So I finished high school when I was 17 and then had to choose what I wanted to do next. So unlike many of you who are doing medicine now, then it was possible to go straight from high school into medicine. Why did I choose medicine? I don't really know, is the honest truth. The truth is I probably got better marks than I expected, and then got some really good advice from my parents and certainly a couple of teachers that trained me. And they suggested that I might find medical training entertaining. I didn't know any doctors. Certainly there was no one in my family that was medical, but I thought I'd take this on. And so this is what my world looked like from 1993 to 1999. I went to the University of Melbourne. For much of that time, I lived at Ormond College. And really, my whole world really centered around this square. I frequented Norton's as much as I could. It is a very different place. It was a very different place then than it is now. But really enjoyed medical school. I enjoyed my time at the university quite a lot, and then moved to St Vincent's Hospital to do my clinical years of training. And there is where I think a large degree of confusion started to set in. It occurred to me that I actually enjoyed my preclinical years more than my clinical years. And I think that in many ways, the things that I struggled with most during my clinical years was the uncertainty about the diagnosis and of patients. I found it very difficult to know when somebody said, I have chest pain, whether they really did have chest pain or were they anxious about something else. And this anxiety really sort of kept going for a while. And after I finished 5th year of medical school, I was pretty certain that I did not want to be a doctor at that stage. So what I then did was in 1998, I took some time out of medical school and I took a scholarship to the University of Oxford and went there to do some basic science. Spent quite a lot of my time there, and then also spent quite a lot of my time back in Melbourne working in zebrafish. This was a time when we were learning lots about the cell cycle, and I worked on a major cell cycle regulator called P16, and worked on this in zebrafish and just absolutely loved it. Thought that the thrill of scientific discovery was amazing, and was smitten by the whole thing. I guess during that time, I also met one of the most influential people, a guy whose name was Bill Robinson. He was a professor of oncology at the University of Melbourne, but he really was an American who, through a very circumferential route, ended up in Melbourne. He came initially to work with McFarlane Burnett soon after his Nobel Prize, but ended up working with Don Metcalf and was in the lab when Don Metcalf and colleagues discovered the growth factors. And Bill was just an amazing human being, and in many ways of kindred spirits who understood the confusion that I had about being a doctor. He, along with others, coaxed me back into medical school because I only had 1 year to finish. And so I went back and finished medical school. But I was still convinced I did not want to be a doctor, and consequently took another scholarship at that stage to go to the University of Cambridge to do my PhD. But about 6 months or 3 months, maybe about 6 months before I left, I wandered into a pub in Burke Street and met someone in that pub who is now my wife. And the discussion we had before I left to go to Cambridge was that it would be a very difficult time for us if I spent 4 years in Cambridge. She too was a doctor, and convinced me that it wouldn't be so bad if I actually did my internship and thought about training to be a proper doctor. And if it wasn't for her, I just would never have done this, and it would have been a huge mistake, because all those anxieties that I had in my early 20s, I don't have anymore, because you just learn to deal with the uncertainty of diagnosis. And so I then trained as a haematology registrar, partly because, so during my training at St. Vincent's, my clinical training at St. Vincent's, we were rotated out in a number of different places. And I guess the thing that attracted me to haematology at the time was things that Jamie just talked to you about. There are few, if any, and in fact, I can't think of any, specialties where you make the diagnosis both pathologically and clinically, and then deliver the treatment for that patient. And that was very attractive to me. The uncertainties that I talked about, actually, I initially thought of training as an intensive care physician, because actually, as it turns out, you can't make up a disease to take you into intensive care. And so when I was in intensive care, what I noticed was that the people that I really liked in intensive care were the haematology patients. Many of them, if not all of them, were there through no fault of their own. Through great adversity, they found courage to deal with the problems. And they were genuinely unwell patients that I felt that I could make a difference to. And so consequently, I then chose to train in haematology and then moved from St. Vincent's to the Alfred Hospital. And at the Alfred, I did 1 clinical year and 2 years in pathology training. During that time, I rotated out to a number of different places, spent a bit of time at the Australian Red Cross as a transfusion registrar, and really enjoyed the breadth of training that the Alfred had to offer at that stage. But I guess what was very clear all along was this drive to become an academic physician was never gone. And so in 2006, I again applied and got the very same scholarship that I had 10 years ago, 10 years prior, except this time my wife got a very similar scholarship as well. And so now the both of us ended up going to Cambridge. And we spent the best part of a decade in Cambridge, where we had 2 children. We did our PhDs, we did our postdoctoral work. I started my lab there. My first PhD student was a haematologist who came from Melbourne to start working with me in Cambridge, and then came back. And this is, unquestionably one of the most important times that we've had in our career, is just learning, what is possible from a scientific viewpoint and understanding how to take that into the clinical arena. In 2014, I came back specifically for this reason. There was a vision to move the Peter MacCallum Cancer Centre, which was in East Melbourne at the time, to Parkville, and for it to be embedded in what was in a great academic environment. The University of Melbourne's across the road, the Peter Doherty's across the road, the Walter and Eliza Hall is across the road, the Murdoch Children's Unit and the Royal Women's is also across the road. And really, there's very few places that give you this critical mass of academic clinical specialty, and that was the main reason we came back from Cambridge. And here, the team we've built in the last 6 years. So we now have 35 people working in the lab. Is my wife, but runs an independent academic lab. She's a medical oncologist. Although we run separate labs, we largely work as one big unit. This is people from 16 or 17 different countries, and it's a fantastic environment to work in. So what I wanted to do is just encapsulate, what the opportunities are. I went from a small square around Parkville to this is what I did last year, as a consequence of going to present research that was done in my lab that had both clinical and scientific meaning. Jamie's talked a little bit today already about, what the opportunities are in haematology, and there are very, very many. And I won't go through all of them. I think the things that many of you will have to consider, especially because many of you come at this at a much older age with greater commitments than, say, Sarah and I did when we did specialty training. The things you'll have to balance with time, and this is largely time, experience, and judgment, is how you balance your career and your family. How you balance being happy versus what is an income. And my strong advice to you here is choose something that's going to make you want to get up in the morning and go to work. Because as a doctor, you'll never be hungry, but you can be bored. So try and do something that will keep you entertained for the foreseeable future. Many of you will come to a decision point as to whether you should do a higher degree. And having spent some time now training many clinician scientists, what I can tell you is that they come to see me to do a high degree in a ratio of 90, 80, 2. 90% of them come to do a higher degree to get a better clinical job. Now, that might be a reasonable thing to do a higher degree for. I'm not sure that that is necessarily the best opportunity to do basic science research. 8% of the people who come to see me and usually end up working somewhere in the lab are those who really have some idea that they might want to be an academic clinician, but they're just not sure. They've never had the opportunity and want to test themselves in a new environment. And I think in many ways, that's been a really big place for me to help people with that kind of career decision. And the 2% are really people where I think I'd fall into, who did or finished medicine by accident. You know, I'd always known that clinical practice was never going to be what I could do full time. That's not to say I don't enjoy it. You know, I absolutely love seeing patients. And the sacrifice of having to trim down my clinical time has actually been harder to take than I would have imagined. But as a consequence of the job I now do, I only spend about 20% of my time seeing patients. And consequently, most of my time is spent in discovery research and sadly management. What type of higher degree to do is an important decision, and there are many of these. And I think really what degree you end up doing after your training depends largely on whether you see yourself being a full-time clinician or being a clinician scientist. Why would you want to do a higher degree, and where would you want to do that, home or abroad? I almost always ask people this question because I think it's important to push yourself out of your comfort environment. If it is at all possible, do your higher degree overseas. Do it in something that will make you unique. I've always emphasized to people, do one thing at a time and do it well. When I reflect back on my clinical and academic training, even though there were many times where I wasn't sure whether what I was doing the right thing, I never tried to do many things at the same time. I just either did medicine or I did science. And then when I felt I was adequately trained in both, then I tried to do both together. If possible, go to a world-leading center that's going to teach you something you can't get here if you're going to go overseas. Ultimately, if you choose to go into a lab, you've got to ask yourself the question, why would you do that? What is the advantage of being a clinician scientist? I guess these two people live in very different worlds. Clinicians often end up with the question of why did this or did this not work? Scientists who never have the opportunity to explore the consequences of the knowledge they generate can sometimes find it very frustrating. And we have, you know, the unique opportunity to straddle both arenas and really understand and use your clinical knowledge to ask scientific questions that will make the most difference to patients. The other thing to impress upon you today is that only about 2% of you, you know, of all medical people who get trained will actually go on to be clinician scientists, which is in many ways an incredible shame, because when you look at the contribution that clinician scientists have made, it's absolutely enormous. 37% of all Nobel Prizes have been won by clinician scientists. 70% of all the leading jobs in pharmaceutical industries, in academic centers, etc., are held by clinician scientists. And really, I think, you know, this is a critical time for people to consider a pathway in clinician as a clinician scientist. Many people worry about, you know, why would I do this? And I guess in some ways, you guys who have come from different degrees might feel less scared about this. But some of the concerns I have when I talk to people who come to see me about doing a higher degree is that they've never picked up a pipette before. They don't have a basic science background, and that is true. You know, medicine does not train you to do basic science. People feel like they will lose their skill set as a clinician scientist, and I think that's absolutely rubbish. You know, some of the best clinicians I know are clinician scientists. I will be less likely to get a good clinical job as I will be out of clinical view. That true is absolutely false. If you're good at what you do, you'll get a job wherever you want. What are the major pros? Well, you get to set the paradigm rather than follow the paradigm. You know, you have complete academic freedom. And as I said to you, it informs your clinical practice, and your clinical practice informs your scientific progress. You know, this inexorable link is absolutely critical for us to continue to contribute in a way that helps improve the way, you know, diseases are diagnosed and managed, particularly in haematology. I'm going to stop there. I was going to actually tell you a little bit about what I do in terms of what is epigenetics, but I think in the interest of time, I think I'll stop and take any questions.
Thank you, Mark. That was also an amazing presentation, and I don't think I actually appreciated how substantial the role of clinician scientists were in medicine. So thank you for letting us know about that. Are there any questions for either of the speakers?
Yeah, I do have one. So thank you so much, Mark, for your presentation. I'm actually a science undergraduate student who find myself extremely interested in both the basic science field and the clinical medicine field. So, and therefore, I think I might eventually go down to actually do the clinician scientist pathway. However, I've researched on the official website for the Australian medical field. I didn't find like a joint degree that is actually like an MD PhD degree. So I'm wondering if I were to go down that pathway, should I go pursue a PhD first or MD first? Thank you so much.
It's a really difficult question, you know, and that's why I guess I was pretty honest with my path to this point. That more than anything was just serendipity, you know. I probably, had I gone off to do a PhD before I did my internship, I never would have come back to be a doctor. And that would have been a shame, because I think I would have been, at least I feel I would have been a less influential scientist, and I would certainly have been a less rounded doctor. Now, if you go and do your PhD during your medical training, and at Cambridge we had lots of these MD PhD programs, the difficulty there is, you know, if you succeed and you really love it, it will take you another 8 to 10 years to get back into the lab. And in that time, science moves on. If you think about what we do now routinely in a laboratory, you know, using CRISPR methodology to precisely cut out or activate genes, that just didn't exist 8 years ago. And as science will move forward, you will feel largely left out. So, you know, although serendipitously, I think the way I did it is probably the way I would try to recommend you do it, which is choose a specialty that you think you're going to be good at. Choose a specialty that you think you're going to be able to do for the foreseeable future, and then find a place to do your scientific training.
Yep, thank you so much.
There's a question in the chat. So there's one for you, Jamie. What would be your recommendation for a pocketbook for haematology?
So I'm presuming you mean in terms of a small reference book. Now, again, I have to probably acknowledge that that when I was a resident and a medical student, I knew little of haematology other than what was in the general things, and so I didn't use one. And since I've been doing my training, I've found rather than a single text to be useful, I typically have utilized the general literature. I find good review articles often more useful than textbooks. And so the one textbook that I have used is Williams Haematology, but it's not really a pocket size, unfortunately. I think there is a smaller version that you could use. So I don't think I have a really good answer to that question. I'm sorry.
Okay. Another question for you, Mark. In regards to lab training for the RCPA component of the training program, is it possible to work as postdoc in Australia or overseas during the advanced trainee period, and how would that contribute to fulfilling the program requirements?
So what is an absolute requirement is that you, if you're going to do your pathology exams, that you do sufficient time in the laboratory to be able to sit those exams. That will require full-time work, you know, in being able to, the training is incredibly diverse, you know, from actually interventional skills, including, you know, doing various biopsies, to blood banking, to, you know, morphology research, morphology, and reading and reporting bone marrows, flow cytometry, etc. That's not something you can do part-time. And I certainly wouldn't recommend that you do that, you know, in a part-time capacity whilst trying to do basic science research, for instance. So you can certainly do 1 clinical year, 2 pathology years, and have your final year accredited if you're doing a full-time research degree. Most of the clinician scientists in my lab have done exactly that. So they've done either 1 clinical year, 2 years in the lab, and then they've come to do their PhD with me. And that can count as your last year of training.
Thanks, Mark. There's a couple more questions. I might leave it at that. Once again, another one for you, Mark. As a clinician scientist, how much of your time do you spend seeing patients and how much doing research, and what is the mix? Thanks.
The mix is entirely up to you. What I will say is that you will be judged the same by both sides, as you should be, right? So, you know, if you're a clinician seeing patients, you need to be as good as any other clinician seeing patients. And so in many ways, you will have to make some decisions about how that is going to pan out for you. So I trained as a haematologist. I did pathology training for the first few years in Cambridge. I, you know, as a locum and then consultant haematologist there, saw patients with bleeding disorders, red cell diseases, bone marrow transplants, lymphoid and myeloid malignancies. And actually I did that for probably about 10 years. But since being back in Australia, the first thing I dropped was non-malignant haematology when I came back, and I no longer saw patients with bleeding disorders, thromboses, or red cell disorders. But then as my commitments have increased, I now no longer see patients with lymphoid malignancies. And actually more and more, I've had to sub-specialize. So now I just treat patients with acute leukemia and the main myeloid malignancies of myelodysplasia and myeloproliferative disease. And that is really where my clinical interest lies, and it sort of marries well with my research interest. From a research point of view, I spend 80% of my time running a lab, but it is a fairly large lab. And then I have a number of administrative responsibilities throughout the Peter MacCallum Cancer Centre.
Thanks, Mark. What are your thoughts on doing a year or two as a research assistant or a master's of, I think, philosophy instead of doing a PhD?
Yeah, very good question. In fact, whilst we were doing this, I was just writing to a doctor who's coming from the UK. She has finished 2 years of training, wants to potentially be a haematologist, but is unsure whether she wants to train in Australia or England, and B, whether she wants to do a PhD. So she's actually going to come and work with me as a research assistant. She'll be the most qualified research assistant in my lab, but I think it would be a wonderful opportunity for her to take some time to work out these questions. I think the thing I'd like to impress upon the people here is that your future career is not a race. No one's got a stopwatch out asking you to get there as quickly as possible. You're better off getting to the right destination than getting to somewhere quickly. And the right destination is doing a job that you feel like you can do for the remaining time. You know, the next 30 or 40 years is a long time to do the wrong thing.
Okay, and just a couple more questions and we might leave it after that. Another question for you, Mark. Do you have any specific advice on choosing a supervisor or lab for a PhD?
Choose a supervisor where your success is equally important to them. Don't go to somewhere where whether you succeed is irrelevant to your supervisor. You know, that's absolutely critical. Choose a supervisor who you think you can get along with. You don't have to be friends with the person, but you have to be able to talk to the person. So I think those are the two things that I would say that you need to really consider when you're choosing where to go and commit your academic future.
Okay, and we have a question from Catherine who wants to do it by video.
Okay.
Hello, good evening, Jamie and Mark. Thanks so much for coming along tonight. My name's Catherine. I'm a final year medical student in Canberra. I actually have already done my HDR degree. My PhD was awarded last year. So my first question, what sort of pathway do you envision for somebody who's done their HDR studies already?
Mm-hmm.
Mine were in a different field, in parasitology. Because I was just noting in your talk that you were saying, you know, if possible, go overseas to do your HDR. But yeah, I'm just wondering sort of what sort of scope would there be in a lab like yours or in other haematology sort of research areas for, would I be looking at a postdoc, or yeah, what's the sort of scope there? Thanks.
So certainly if you've done a PhD, you know, whatever research you do next will be obviously as a postdoc. Going overseas is not just for the sake of going overseas. I think going overseas, you know, enables you to test yourself in a different environment, and in a place where they will treat patients differently to the way we treat patients here, and B, have a different culture potentially to what we have here. Science is, as you know, relatively challenging, unlike medicine, you know, where if you do the work, you'll probably be okay. In science, if you do the work, there's still no guarantee that you'll be okay. You know, quite a lot of it depends on luck and knowing when you're lucky and knowing how to make the most out of that. Having said which, I don't consider it a prerequisite for people to go overseas. I always encourage them and I always ask them why they would or would not do it. And many people have very good reasons not to go overseas. I have in my lab right now a final year medical student who is about to finish his medical degree, who did his PhD before he did medicine, but has always felt like he's just missed out on the scientific discovery process. So he came back and has spent the last 6 months with me and will continue to be sort of involved in the lab in some way until he gets an opportunity to go back and do his formal postdoctoral training. So I think you've just got to find the right people that are going to be able to support you with that.
Thank you. I do want to be a clinician as well, which is, you know, why I'm thinking of this clinician researcher path. So I'm looking at, you know, training programs, and because I'm in my final year and we're actually in the middle of applying for internships, I'm kind of just wondering if you wouldn't mind giving me some career advice. Is there a different reputation of training programs around Australia for haematology? Like, where should I be looking to go? And does it really matter where I do my internship? Because it's quite hard to apply interstate, as I'm finding.
Yeah, so Jamie might be able to help you because Jamie obviously moved states to do his internship, whereas, you know, I moved a couple of 100 meters down the road from where I live to do my internship. So look, I think, you know, if you're adventurous and courageous enough to get up and move, that's what you should do, right? Because you've got nothing to lose by doing that. If you don't like the place you're at, well, you'll just move again. In terms of where is the right place for you to do your internship, and will that necessarily influence where you do haematology training? I think in some ways yes, and in some ways no. So in contrast to what I was saying about when it comes time for you to be a consultant, you know, what if no one's seen you or heard of you, etc. You will be judged on what you've achieved and done at that time. Whereas, you know, in some ways your training is partly influenced by the people making the selection process and choosing people who go into programs, and they, like it or not, will be influenced by the people they know, right? So I think going to a place where you think you might have a sustainable training path is always worthwhile. But having said that, Jamie did it very differently, right? You know, he moved to Melbourne to do his advanced training, so he might be able to help.
Yeah, I can add a few things. I've had a bit of an atypical path. I think growing up in Perth, it's easy to have a chip on your shoulder about everything that's happening on the other side of the country. And I always assumed that I would move at a number of points in time. And I had the opportunity initially to move for med school, and then thought I was going to do for my intern year, thought I was going to do for BPT, but other life things kind of popped up in the way. And so advanced training was the obvious time. I think one thing I'd say is that it's important to do whatever you're doing well at that time. And I think whilst it's easy now when you're sitting in your final year of med school, knowing you want to do haematology, to go somewhere that's going to set you up for haematology. But there's a lot of stuff to learn in that intervening gap. To be a good haematology registrar, you've got to be a good general medical registrar. To be a good lab haematology registrar, you've got to be a good clinical haematology registrar. And all of that knowledge builds up in a pyramid. And when you really know the foundations, it gives you a lot more flexibility to learn the details. And so I would go somewhere for your internship that's going to give you a really, really good foundation. What made it easier for me to move to Melbourne to a new system was feeling like I was a really good general medical registrar. And so all of that other stuff that I was trying to deal with as an advanced trainee, sick patients, family meetings, all of those things which are real parts of doing the job, was already taken care of because you'd focus on the basics. So I'd focus on what you're trying to get out of your year, focus on what you want to get out of your intern year and what you want to get out of your resident years and your basic physician training and your haematology training. So for me, the most important point where I felt I could differentiate at the move was the haematology opportunities that were available in Melbourne versus in WA versus that were available in basic physician training. It's always good. I've moved hospitals a number of times, I've moved states, and every time I've moved, I've learned something different about the place I'm in. There's a lot of dogma in various places, people treat people differently, people have different cultures, and you take something different from all of those places. And so I would suggest that getting experience in as many different environments as you can is going to serve you really well.
Okay, thank you very much.
Okay, I think we've reached the end. Once again, thanks so much to Mark Dawson and Jamie Kuzich. You've both been really good speakers, and it's been really interesting hearing and learning a lot about stuff I didn't actually really appreciate before this seminar. So thanks again.
You're welcome.
Thanks, Kevin. Bye-bye.
Guys, thank you.
Thank you. Thank you so much.
Thank you.